Am I audible?
Yes, madam, you're audible.
Thank you. Let me mute everyone. Welcome to the Neurosurgical Case Room. We are going to do the second session of Falcotentorial Meningiomas today. Let's go back. I don't know why we came. And after we are done with this, tomorrow we have the fourth episode of Global Neurosurgical Conversations. I'm going to announce the guest on the WhatsApp group in a while, inshallah. And on Monday and Tuesday, we are going to cover two surgical approaches which are related to falcotentorial meningiomas, but both of them would need extensive sessions of their own. On Monday, we are going to do the occipital transtentorial approach, and on Tuesday, we will either do the bilateral occipital transtentorial transfalcine approach or the skit approach, supracerebellar intratentorial. I'm still deciding which one we would do. So, given that we have figured out the schedule for the coming few days, well, let's move on to today's topic. When we say that we want to discuss the clinical presentation of falcotentorial meningiomas, I am sure you all would remember by this point what the exact location of the lesion is. For example, if I'm going to draw here, this is Fox, this is the tentorial junction, and then this is the tent. This is the sessile view, and here this is the axial view, sort of, because the tentorium cerebelli is in the axial plane, right? And where is the lesion? The lesion is usually somewhere around here. And we discussed what were the important structures were around this area. Starting from the vessels, we have the inferior sessile sinus, we have the straight sinus, we have the great vein of Galen, we have other deep cerebral veins like the internal cerebral veins or the basal vein of Rosenthal. Apart from that, these are the major vessels, right? Apart from that, we also have branches of PCA passing through this posterior incisural space. We also have some branches of superior cerebellar artery. We will have the cranial nerve fourth. We write this here, cranial nerve fourth, sometimes cranial nerve six, sometimes five as well. Please keep yourself muted, whoever this is. So these are some of the important neurovascular structures. Remind me if I'm forgetting any neurovascular structure. We are going to come other as well. Regarding the actual neural structures, we are going to have midbrain right around the posterior incisural space, right around here. Let me mark it. So this is where the midbrain is going to be, roughly. But there is going to be the midbrain. Apart from midbrain, we will also have the pineal gland, right? And more importantly, why is this important? Because aqueduct of Sylvius could start here, or third ventricle. So this is the CSF pathway as well. Why are we revising every single structure that we have already covered? Because if we remember all these structures, the clinical presentation is very, very easy to understand. Apart from all of this, we also know that there is corpus callosum running right around the fox, like this. And particularly in this region, we have the splenium. So now we have splenium, we have the CSF pathway, we have the midbrain, we have the pineal gland, PCA, superior cerebral artery, we have the fourth nerve, sometimes the sixth nerve, and all these major vessels. If the lesion is going slightly posteriorly, it can also involve the transverse sinus, or it can also involve the torcula. Are we all on the same page regarding this? Am I audible?
Yes.
Okay, I don't get why everybody is so quiet today. Let me clear this. So now, since we have discussed all the relevant structures, your patient is going to present with symptoms that will be driven by the direction of the tumor growth. Whichever way the tumor is growing, that particular way the patient will present. For example, if the tumor is growing supratentorially, then the presentation is going to be very different because it is going to put pressure on the occipital cortex, etc., etc. If it is growing infratentorially, then it is going to put pressure on the cerebellum. It is also going to put pressure on the brainstem, especially the pons, then the pineal gland. So your presentation is going to be dependent on the exact location of the tumor and the direction of the tumor expansion as well. And obviously, obstruction of CSF pathways comes as a freebie with this. So if the CSF pathway is blocked, we know that the patient is going to present with raised ICP. Along with that, patient can have Perinod syndrome. Let me write it. And because of raised ICP, especially if it is due to hydrocephalus, patient can have sixth nerve palsy secondary to raised ICP and hydro. Papilledema can be there, headache, nausea, vomiting. You know the drill, how raised ICP and mass effect present. Let me move. Patient can also have progressive generalized headaches, especially those that are worse in the morning, or they increase with Valsalva maneuvers, with straining, with constipation, etc. Nausea and persistent vomiting can be there. Fundoscopic finding is really, really important because it is going to tell us how high is the ICP, and should we expect secondary optic atrophy, because the lesion is, if it is already causing compression on the occipital cortex, we are already going to expect some form of visual impairment, Apart from that, altered sensorium. Can somebody from the listeners unmute themselves? Let me know what will be the pathology or pathophysiology of altered sensorium here. What will be the causes? Anybody? It's not weekend yet, is it? Why is everybody behaving as if it's a class on the weekend? Okay, so yes, Dr. Fatma is saying ICP and hydro. Yes, that is a very important reason of altered sensorium. There is something else as well. Where is the tumor putting the pressure on? Midbrain, right? Brainstem. So what is in the brainstem that will cause decreased or altered sensorium? That's right. RAS is going to be involved, Dr. Subham. This, if RAS is involved, patient sensorium is going to be altered. Patient can be lethargic, confused. Patient can be somnolent, even if you do not see a significant mass effect or significantly raised ICP or hydro. If there is direct compression over the midbrain and RAS is affected, then patient can present with altered sensorium. To move on. So we have homonymous hemianopsia or cortical blindness. Both of these are possible. Usually, if it is a single-sided lesion, what do I mean by a single-sided lesion? This is Fox, and the lesion goes like this. If it is a single-sided unilateral lesion, patient is going to present with homonymous hemianopia. If it is a lesion which has bifalcine extension, and it's growing on both sides and putting pressure on both sides of occipital cortex, which sometimes is the case, patient can have cortical blindness with or without macular sparing. Apart from that, patient can also have Perinod syndrome. Why? Because there is direct compression on the tactile plate of midbrain, and patient can have upward gaze palsy, light and near dissociation, convergence attraction nystagmus. We know this. So what if the tumor grows like this? Let me draw. What if this is the fox and this is the tent, let's see, this is the cerebellum. Please excuse my very poor drawing skills. They are better. This is just a screen. So if the lesion grows here, then apart from the occasional chance that it will block the CSF pathway, it is also going to present with cerebellar syndrome. Patient can have gait ataxia, steadiness, wide-based gait, frequent falls, dysmetria in coordination, dizziness, and vertigo. So this patient, along with some symptoms of hydrocephalus, they are also going to present with cerebellar lesion, and we might think that there's a primary pathology in the posterior fossa. Clear? So there will be direct mass effect on brainstem if the direction is anterior. If there is direct effect, then there can be involvement of cranial nerves directly. Third, fourth, sometimes sixth can be involved secondarily. Apart from that, patient can also have spastic quadriparesis or hemiparesis. There is a particular case report in which patient had a bilateral Falcotentorial meningioma, but they presented with spastic quadriparesis. So it was a very rare presentation. And if somebody reminds me, I will leave the link on the group. Apart from that, even if there's not complete paralysis, patient still can have long tract signs, hyperreflexia, spasticity, etc., etc. Apart from that, third nerve palsy, fourth nerve palsy, which can lead to diplopia and affected extraocular movements. And obviously, if it is a midline deep lesion, and especially if splenium is there, corpus callosum splenium, if it is there, then there can be impairment of speech. There can be mild memory impairments. There can be disorientation, slowed processing, apathy, abulia, emotional lability. So the presentation of Falcotentorial meningiomas is really, really vast. It is going to vary from case to case, depending on that particular tumor's location. I found it easy to divide them in certain syndromes, sort of, in how they present. So the presentation can be hydrocephalic. It can be mainly visual or tactile, where they are presenting with homonymous immunopia and upward gaze palsy. It can primarily be cerebellar, or it can primarily be brainstem or long tract with hyperreflexia, long tract signs, etc. And cranial nerve palsy's involvement directly. So the investigations. Nothing is new here. They are the usual investigations we get for almost all the meningiomas. We need the MRI brain with contrast, and we need the cerebral angiography. Apart from that, we are going to need fundoscopy and perimetry. Regarding angiography, we would either need MRV, MRA, or CTA. The best option is DSA, even though CTA usually suffices in a lot of cases. And then you want to have fundoscopy and perimetry, because if there is prior visual deficit, you want to document it for the sake of prognostic information and for saving yourself from unnecessary litigation as well. I have already written something here, but let me know what is your opinion. What do you think about embolization in Falcotentorial meningiomas? Can somebody turn on their mic and discuss?
Embolation reduce the size of the vascularity of the meningioma so that it will not bleed intraoperatively.
Okay, so is it a norm at your center doing embolization for
Yes.
Falcotentorial meningiomas?
In Falcotentorial, we don't do means we do surgeries, but I've never seen. But in sphenoid wing meningiomas, glenoidal meningiomas, we do embolation.
Okay,
Big thing.
no, I think you mistook my question. I wanted to ask anyone's
Falcotentorial.
experience regarding the Falcotentorial meningiomas, because usually what happens, there is a mixed supply, mixed feeders. Why mixed? Because we know that the tentorial artery of Bernasconi and Cassinari. It's a very pretty name, by the way. So that originates from ICA. And apart from that, patient can have some branches from middle meningeal artery. Patient can have some branches from direct other branches from external carotid artery. So the supply is usually mixed. The feeders are mixed. And usually it's really difficult to target the feeders successfully. They are usually deep or relatively inaccessible. So the success rate is not very high as far as the literature is concerned. But we still get a DSA done because we want to identify the feeders A. B, we want to take a really good look at the major veins during the venous phase because you want to be sure if your straight sinus is patent or not. What about the vein of Galen? And what about the inferior sagittal sinus? So you want to be sure if they're patent or if there is occlusion, what degree of occlusion is there. So DSA will help you in planning the surgery in a way which CTA cannot do. I hope it is clear. Let's move on. Let me know if it is not.
Yes, madam.
Okay, so this is a repetition of the slide. Please ignore it. We have come to the DSA and we have discussed these arteries. Yes, I forgot the PCA. The most important concern here is the tentorial artery, which is the artery of Bernasconi and Cassinari. It comes from the ICA. Then we have some branches from PCA, sometimes posterior choroidal arteries. Venous phase is really important for us. Pre-op embolization, people have mixed reviews. Different authors have different experiences with it. Let me know if somebody is working in a specialized endovascular setup. They can leave their particular experience either on the WhatsApp group or uh, on the comment section in the video. I have never experienced any preoperative embolization in Falcotentorial Meningiomas, so I can't say much about it. This is the question of the day. How to choose the surgical approach? Can someone unmute and let me know what they think about how they would choose the approach? We discussed it briefly yesterday, but there are other factors as well.
Can we go for, madam, hospital opens approach, hospital transtentorial?
Okay. Okay, listen to the question again. The question is how to choose the surgical approach. So to choose the surgical approach, what are the things you are going to need? You're going to need the size, right? You're also going to need the laterality. How are you going to do an occipital transtentorial approach if it is a bilateral tumor? You won't be able to, right? So you will need the laterality. Apart from it, what other things you would need to know? Okay, Dr. Fatma has a very detailed answer. We would need the classification, yes, Bassioni, because that is based on the vein of Galen displacement. That's right. We want to know the position of the vein of Galen. Apart from that, the direction of the tumor growth, and yes, the venous patency. So you're right. Apart from the size and the laterality, we will need to know the status of the veins, and we will need to know the galenic system location and its direction of displacement. There's one more thing. Can somebody let me know? So that is tentorial tilt. If the tilt is really high, we are going to discuss it separately if it does not make sense right now. But if the tilt is really, really high, you cannot successfully do the occipital transtentorial approach. And lambdoid torcular inversion, Dr. Fatma, I have never read about it. Let me know if you have any details. Lambdoid torcular inversion we see in the Tandy-Walker malformation, usually. Here we want to see the tentorial tilt, the angle of the tent. If it is too steep, you will have a very good approach if you're going under it, because the tilt is high, so you would be able to have a good exposure. But if it is steep and tilted like this, let's say this is the fox and this is the tilt. Now, if you're going here, the lesion usually is here. So you will have a really hard time in accessing the lesion. You can still, not saying that you can't, you can incise the tent and change the territory slightly, the trajectory, but it will be still difficult. If the tilt is very steep, skit is much easier because now you're just following the natural corridor. So there are multiple factors when we are deciding which surgical approach we are going to choose from. Let's move on quickly. We are running out of time. So yes, the epicenter and direction of the growth is really, really important. Dr. Lee is asking, do we get off degree of tilt that we cannot do skit anymore? I'm sorry, I'm not getting your question. Uh, I'm not getting your question, but let's come to the tentorial tilt slide and let's see if what you asked got clear. So we want to know the direction of growth. If it is growing supratentorially, if it is growing infratentorially into the posterior fossa space, if it is affecting the brainstem, or if it is, if you know, bilateral dumbbell shaped, a few meningiomas that we saw previously. Apart from that, vein of Galen relationship is really important. How do we identify that? We identify that with the help of Bassioni classification, sometimes a study classification as well. We want to know where they are displaced and what is the laterality. Apart from that, are they patent or are they occluded? This is one example, and let me know which approach would you like to go from here and why. In the first image, there are different images.
First one, madam, A is Krause approach, supracerebral infratemporal approach.
Okay, yes, it's relatively easy. You can see that most of the lesion is infratentorial. If you go supracerebellar infratentorial, you have a very natural corridor here.
Yes, ma'am.
Let's not discuss B because we do not have the sagittal and coronal images. What about C?
C, madam, we can go for hospital transtentorial. We can cross the tent and go.
Okay, so if I
OTT.
receive this patient, if I receive this patient on my OPD, what I'm going to do is I'm going to need more information about this, because this can be accessed inferiorly and
Both,
this
yes,
can
ma'am.
also be accessed superiorly. So I would need
Yes,
to
ma'am.
know the location of the vein of Galen, and I will also need to know if straight sinus is involved, occluded, or whatever is going on with the veins. So this is a lesion in which I would need more information before I plan my surgery, right? D is the one I was talking about when someone said that they would go occipital transtentorial, because lesions that are going bilateral, you won't be able to access
Yes,
them
ma'am.
nicely from the unilateral approach. For these, we use the BOT approach, bilateral occipital transtentorial transfalcine. It's a mouthful of an approach. Okay, personalized approach for meningiomas. That's right, Dr. Fatma. We choose it based on a lot of factors. BOT is really good. It gives you access to both the supratentorial compartment and the infratentorial compartment as well. Apart from exposing, you know, all the major structures, but obviously it comes with a lot more morbidity. So if we can get away with another approach, we should. Let's move to the next slide. So what do you think about this one? Somebody saying something?
Madam, we can go for hospital transtentorial. After that, we can leave some residue and we can go for SRS, stereotactic radiosurgery.
That's
We
right.
used to
That
do
would
in
be
our
that
center
would be a good approach. We can go occipital transtentorial,
and can go for
and
SRS.
yes, and the contralateral side in which you can see some extension. It's very small, so you can access it if you incise the involved forks. It's accessible. There is another approach in which we can go through. Can somebody name it? What if I say that I won't go occipital transtentorial? Okay, so Dr. Fatma is saying bot followed by SRS. Why, Dr. Fatma? Why bot in this patient? Patient does not have enough infratentorial uh, lesion. So posterior parietal interhemispheric, if we go via here, that will also be a viable approach. You would go in the interhemispheric space because this is growing mostly supratentorial. So that can be used as a corridor as well.
I have seen this case operated by my chief in unilateral OTT only.
Or which one? This one?
Yeah,
Yeah, that's
since
right.
it's a
BOTT would be very extensive for this lesion. It does not have enough infratentorial extension, or it does not have enough contralateral extension either. So this can
yeah,
be
yeah.
easily approached from a unilateral corridor. But yes, we do have the preferences. We can go occipital transtentorial, but we can also go posterior interhemispheric as well.
Even if it is in the more towards the equally towards both sides, I think since it's a meningioma, it will have a proper plane. So I think we can slowly dissect and take it off.
Yeah,
Um,
there is also CSF cleft also present, madam. Plane is good.
yes.
Cleft is there.
Regarding that, regarding how much we can access the contralateral lesion, please remember that we are dealing with the visual cortex here. So if we are going via unilateral occipital transtentorial approach, and let's say there is a lesion that is significantly on the contralateral side like this, it would be really difficult because then you will have to retract the occipital cortex to a significant degree, and it might lead to permanent deficit. So the corridor is good. It's a beautiful corridor, but it comes with its own costs, and we do not want to be, causing a permanent neurologic deficit. Okay, Dr. Fatma is saying precuneus will be compromised. Precuneus is a relatively non-eloquent area, and it is regularly used as a surgical corridor because let's have a separate discussion on the precuneus, but precuneus is mostly non-eloquent. It can be used as a corridor. We will go into hemispheric though.
Madam, we can
Just
go for pre-operatively. Can we go for functional MRI to know
yes, we
functional
can.
MRI?
We always have that option, especially if a patient already has homonymous immunopia, and we want to be sure that there is no displacement of occipital the optic tracts. So DTI obviously is an option. You
Yes,
play
madam.
with all the tools that you have. Depends on the tools that you will have, particularly. So we want to know what the relationship with the tentorial incisura is, and if it is compressing the brainstem, if it is compressing the superior vermis. Apart from that, we would want to know the tentorial angle. Let's see, what do we mean by a tentorial angle? So there is this imaginary line between the nasion and the tuberculum sella and the angle of the straight sinus. Normally, it should be around 27 and 52. Patients who have congenital disorders like achondroplasia, etc., they can have abnormal angles. And let's look at this. This is a normal tentorial angle. You can see the imaginary line from nasion to the direction of straight sinus. And this is the straight sinus. This is nasion and tuberculum sella. We measure the angle here, usually between 27 to 52. We clear this. So this is not as steep. Even if we go here and we incise the tent here, we will be able to access the lesion, right? But let's look at this tentorial angle in a patient with achondroplasia. These images are from Radiopedia. You can see how steep this is. So God forbid, if this patient has a lesion here, even if it is going slightly transdental, if it is here, you can see that it would be
You can go
really
for
difficult
you can
to
go for
go.
madam this case you can go for Krause approach, supracerebral infratentorial.
That's right. So in these patients, this is why we want to know the tentorial angle in the first place. If it is steep, we don't go via the supratentorial approaches, we go via the infratentorial approaches. They will naturally become a corridor because now you are going to enter from this. Let me clear this one and change my color. You're going to go via this, look up, and your pathology is going to be there safely. The problem is, what if we have vein of Galen here, which is displaced inferiorly? Then what would be your back out option?
TT only. But TT only last. This also difficult.
We can go via posterior interhemispheric, right?
This one.
So even if
Infratentorial.
the angle is
Infratentorial.
and we are getting a natural corridor in this kit, the supracerebral infratentorial approach. If the galenic system is displaced downwards, it will still be very big of a effect because when you enter, the first thing you're going to see is the vein of Galen and not the pathology. So not saying that it's not doable, but it will be difficult. This is a simple summary. I have an algorithm from the MEFT as well. If it is a dominant supratentorial mass, vein of Galen is pushed inferiorly. We can go occipital transtentorial if it is a unilateral mass, or contralateral, but the contralateral extension is not big. If it is dominantly infratentorial mass, obviously the Krause's approach is very good, this kit. Then if it is dumbbell tumor, the true symmetric tumor, then we can go combined suprainfratentorial or the bot approach. This is from FT, and they are using size as a cutoff. If the size is less than 3 centimeter and the patient is not a good candidate for SRS or STR, then they can go for occipital transtentorial. If the size is more than 3 centimeters, they are advising what here? Bilateral occipital transtentorial transversal. We will probably discuss this approach on Tuesday, inshallah ta'ala. Clear this. So this is the kind of tumor that we were discussing with previously. Tilt is relatively high. You can see that the tentorial angle is relatively high, and there is a very natural corridor here. We can go via skit, but what is the problem? The problem is this particular structure
Vein of Galen.
looking at us very sneakily. So we do not want to encounter it. So in these patients, the posterior interhemispheric can be a good approach.
Mhm.
This. These are just a few cases I wanted to include for some brainstorming. So what do you think you would be doing with these patients? This is a single case.
Madam, this case we can go through right posterior and that ventricular. You can through the ventricle also. You can approach.
Could be. Is this a good case for bot? We could go. I think we can go via bot. We can go via multiple approaches. The problem
Ventricle
with
will be shorter route.
sorry,
Madam, ventricular will be shorter route.
I am not sure what you're trying to say. Please write it down in the chat box. So Dr. Fatma is saying she would choose interhemispheric. Yes, interhemispheric is also doable, but what I'm concerned with is around 50% of the lesion is infratentorial. If I draw a margin here, let me see. If I draw a line here, roughly 50% of it is infratentorial. So it would be, no, Dr. Subham, why would you want to go via the ventricle?
No, I just want to know whether we can go. I'm so curious to know.
I am not sure. I am really not sure because personally, I would not want to breach ventricle in a patient whose ventricle lining is intact because the trade-off is really high. If it can end up in a lot of other complications, it can end up in IVH, chemical meningitis, CSF leak. So I would not want to enter the ventricle. That would be a nightmare for me. I think I'm not sure if someone else has any experience. Let me know if someone else has. I would prefer bot in this or posterior interhemispheric. Bot would be my first bet though. Dr. Fatna wants to go posterior interhemispheric. Does someone else want to contribute? Be clear. Move to the next image. This is just a warm-up. We are not going to do the approach today. This is just a warm-up. They were beautiful images from the Neurosurgical Atlas. And this is the occipital transtentorial approach. This is a cadaveric dissection. You can see how beautiful the corridor is. The only problem is that this is an eloquent cortex. Apart from that, it's a beautiful corridor because you are going right into the natural territory. What you do is you gently retract the cortex towards the other side, assisted by gravity, and then you go deep in. This is the junction. You can see the straight sinus here. This is the tent. This is the falx. You go in and then you incise this portion of tent very carefully because fourth nerve passes right around it. You don't want to damage it directly. Once you open it, this entire portion opens. You can see in this image in the P that tent has been incised, and you can take a really good look at the cerebellum below and at the pure internal cerebral veins. If we go slightly posterior, we can also see the vein of Galen. On Monday, we will discuss occipital transtentorial, inshallah. Let's move. And this is an illustration from Mefti showing the same approach where they have ligated the sinuses, probably in a case where the sinuses are already occluded. So we are going to continue on Monday and Tuesday, inshallah. They will be my last sessions before I take a break. Tomorrow we are going to have the neurosurgical Global Neurosurgery Conversations, episode 4 with James Rutka. I'm going to put up the link right now. Thank you so much, everyone. Please leave me questions, feedback, anything that you want to add on the WhatsApp group. Thank you.
Thank you so much, Doctor. Assalamu alaikum.